The flamethrower was never considered a complicated weapon, but when military doctors began piecing together what actually happened to the men it touched, they realized the fire was almost the least of it. What followed was a biological process so severe it was unlike anything else that many physicians had encountered in combat medicine. The modern military flamethrower was invented by German engineer Richard Fiedler in 1901. The German army officially adopted it in 1911 and created special assault units called Flamethrower-Abteilungen, or flamethrower detachments, to operate the weapon in the battlefield. There were two main versions. The Kleef, or small flamethrower, could be carried by one soldier and could shoot a stream of burning fuel about 18 meters. The Grof, the larger version, needed a crew and could reach around 36 meters. Both used liquid petroleum fuel stored in tanks, which was pushed out under pressure and ignited at the nozzle. The first major combat use happened on July 30, 1915, during the Battle of Hooge in Belgium. German assault troops attacked British trenches near Ypres on the Western Front. The British soldiers had never seen a weapon like this before. There was no training, no procedures, and no real way to defend against it. British Army medical records from Hooge describe soldiers arriving at casualty stations with severe burns to their faces, hands, and bodies. Many died before reaching medical care. Those who survived long enough to be treated were often considered beyond saving, because field hospitals in 1915 had very limited resources. The fuel used at Hooge burned at temperatures above 1600 degrees Fahrenheit, roughly 4 times hotter than a kitchen stove. At those temperatures, human skin can begin breaking down in less than 2 seconds of direct contact. Doctors at Hooge were witnessing what are now known as 3rd and 4th degree burns. 3rd degree burns destroy all layers of the skin. 4th degree burns go even deeper, reaching muscle and bone. In the worst burned areas, soldiers often felt no pain because the nerve endings had already been destroyed. The pain came from the surrounding areas, where the skin was badly damaged but still alive. Military surgeons during World War I repeatedly noted that severe burns caused a type of suffering different from gunshot wounds. It wasn't a quick, sharp pain. It was constant, overwhelming, and often continued without relief. The first major danger is not the burned skin itself, it's fluid loss. Healthy skin acts as a protective barrier that keeps fluids inside the body. When large areas of skin are destroyed, blood plasma begins leaking out through damaged tissue and blood vessels at a rapid rate. This condition is called burn shock, also known as hypovolemic shock. The heart continues pumping, but there's less fluid available to circulate. Blood pressure drops. Organs such as the kidney, liver, and heart begin receiving less blood. Even parts of the body far away from the burns can start to fail. The amount of fluid loss after a major burn is enormous. In 1968, Dr. Charles Baxter at Parkland Memorial Hospital developed the Parkland formula, which doctors still use to estimate how much fluid burn patients need during the first 24 hours. The formula uses the patient's weight and the percentage of the body that has been burned. For a soldier weighing 70 kilograms, or about 154 pounds, with burns covering 50% of the body, around 14 liters of intravenous fluid would be needed in the first day just to keep the organs functioning. Without that fluid, death from shock could occur in as little as 45 minutes in the most severe cases. For burns covering 70% or more of the body, many victims died within 2 hours if fluids were not replaced. On a World War I battlefield, this level of treatment was impossible. Intravenous fluid therapy wasn't available in frontline positions, and even field hospitals had very limited capabilities. A second deadly problem involved breathing. Flamethrowers produced extremely hot air along with toxic gases such as carbon monoxide, hydrogen cyanide, and smoke particles. Anyone caught near the flame could inhale these substances. The lining of the throat and lungs often began swelling almost immediately. Depending on the severity of exposure, the airway could completely close within 30 minutes to 4 hours. This condition is known as inhalation injury and became one of the leading causes of death among flamethrower victims in both world wars. It was especially dangerous because it was almost invisible. A soldier might appear badly burned but stable, only to suddenly suffocate when swelling blocked the airway from the inside. By the start of World War II, flamethrowers had become more advanced. The biggest change was the fuel. In 1942, a team at Harvard University led by chemist Dr. Louis Fieser developed a new incendiary mixture for the U.S. military. By combining gasoline with naphthenic acid and palmitic acid, they created a thick gel that stuck to surfaces and burned much longer than ordinary fuel. The name for napalm came from these ingredients. Napalm made flamethrowers far more deadly. Earlier fuels could sometimes be brushed off or extinguished by rolling on the ground. Napalm could not. It continued burning, even when covered. Temperatures reached between 800 and 1200 degrees Celsius, and the fuel could keep burning for 15 to 30 seconds after contact. The U.S. military introduced the M1 flamethrower in 1942, and later upgraded it to the M1A1. The weapon was carried on a soldier's back and consisted of 2 fuel tanks and 1 nitrogen pressure tank. Fully loaded, it weighed about 68 pounds. Its maximum range was around 46 meters, and it carried enough fuel for roughly 7 to 9 seconds of continuous firing. American forces first used these weapons in North Africa and later throughout the Pacific. Military medical records showed a consistent pattern. Soldiers directly hit by napalm for more than 2 seconds often suffered burns covering 40 to 60% of their bodies. Exposure lasting 4 seconds or longer usually caused injuries that could not be survived under normal battlefield conditions. Doctors measured burn severity using total body surface area, or TBSA. A common method called the rule of nines divided the body into sections. Each arm represented 9%, each leg 18%. The front of the torso and the back also 18% each, and the head 9%. A soldier struck across the front of the body by a napalm stream could suffer burns covering 36 to 45% of the body in less than 3 seconds. At 40% TBSA burned, average survival without immediate medical treatment was usually between 4 and 12 hours. At 60% TBSA, survival often dropped to 2 to 6 hours. At 70% or more, most victims died within 1 to 3 hours if they received no treatment. The Pacific War saw the largest and most documented use of flamethrowers in military history. Battles such as Iwo Jima, fought from February 19th to March 26, 1945, and Okinawa, fought from April 1st to June 22, 1945, relied heavily on flamethrowers to destroy fortified Japanese positions. Japanese defenses were built around underground bunkers, tunnel systems, caves, and reinforced concrete pillboxes. Rifles, grenades, and many other weapons often struggled to destroy these positions. As a result, American forces increasingly relied on flamethrowers. Both the M1A1 backpack flamethrower and the M4A3R3 Sherman Zippo tank were widely used. The Zippo tank carried about 290 gallons of napalm and could maintain a continuous stream of fire for more than a minute. During the 36-day Battle of Iwo Jima alone, American forces used an estimated 1,000 to 1,500 flamethrower fuel loads. When flamethrowers were used against enclosed spaces such as caves, tunnels, and pillboxes, the situation became even deadlier. Fire rapidly consumes oxygen. Carbon monoxide levels rise quickly. Superheated gases filled the confined area. Many Japanese defenders trapped inside these positions died from suffocation and carbon monoxide poisoning within 30 to 90 seconds, often before the burns themselves would have become fatal. U.S. Marine Corps reports from Iwo Jima repeatedly noted that defenders inside pillboxes struck by flamethrowers showed no signs of life when American troops later entered the positions. Most were dead within 2 minutes. The burns alone were fatal, but the lack of oxygen and toxic gases usually killed them even faster. In open areas, survival times were longer. Medical reports from both Iwo Jima and Okinawa recorded Japanese soldiers with severe napalm burns who survived long enough to reach treatment areas. Those with burns covering more than 50% of their bodies usually died within 3 to 8 hours because the Japanese medical system on the islands had largely collapsed under the enormous number of casualties. The Korean War, which began on June 25, 1950, introduced a major medical change that improved burn survival for the first time since World War I. It was the Mobile Army Surgical Hospital, better known as the MASH unit. Forward surgical hospitals had existed before, but Korea brought two important improvements. MASH units were placed much closer to the front lines, and helicopters were used to evacuate wounded soldiers. During World War II, the average time between injury and surgery was about 10 to 12 hours. In Korea, helicopter evacuations reduced that time to about 35 minutes. For burn victims, those lost hours often meant the difference between life and death. Medical teams could begin replacing fluids sooner. Doctors could also perform emergency procedures to keep the airways open before swelling blocked breathing completely. American forces used the M2-2 flamethrower during the war. It replaced the M1A1 and carried about 18 liters of napalm fuel. Its effective range was between 20 and 40 meters. The weapon was used extensively against bunkers and defensive positions along the 38th parallel. Records collected by MASH units and later included in a 1953 Army Surgeon General report showed a clear improvement in survival. Soldiers with burns covering 20 to 40% of their bodies who received intravenous fluids within an hour survived about 75 to 80% of the time. For burns covering 40 to 60% of the body, survival rates ranged from about 40 to 60% if the soldier reached a MASH unit within the average 35-minute evacuation time. For burns above 60% TBSA, survival remained very low. Even with rapid evacuation and modern treatment for the time, fewer than 25% survived. A 1952 study, published in Annals of Surgery, reviewed burn casualties from several wars and found that burns covering more than 60% of the body had been almost universally fatal in military field conditions both during World War I and World War II. Korea's MASH system only improved those odds slightly, but it proved something important. The faster medical treatment reached a burn victim, the better their chances of survival. By the early 1960s, burn treatment had improved enough that doctors could make fairly accurate predictions about who would survive severe burns and who would not. A French surgeon named A. Beau created a system called the Beau score to help estimate a patient's chances of survival. The formula was simple. Doctors added the patient's age to the percentage of the body that had been burned. A score of 100 meant there was roughly a 50% chance of death, even with treatment. A score above 140 was considered almost impossible to survive with the medical technology available in the 1960s. For example, a 20-year-old soldier with burns covering 60% of his body had a Beau score of 80. With good hospital care, he had a reasonable chance of survival. A 40-year-old with the same burns had a score of 100 and faced a much higher risk of dying. However, these calculations assumed the patient reached a hospital. On the battlefield, where treatment was often delayed, fluid loss alone could kill a burn victim within hours, regardless of the score. Age mattered because younger people generally had stronger organs. The kidneys were especially important. After a major burn, blood volume drops and harmful inflammatory chemicals spread through the body. The kidneys often begin to fail, a condition known as acute kidney injury. Doctors monitored urine output to see if the kidneys were working. If urine production dropped below 0.5 millimeters per kilogram per hour, it was a warning sign that kidney failure was beginning. Without enough IV fluids, kidney failure could quickly lead to total organ failure. The location of the burns was also extremely important. Burns across the chest created a dangerous problem that had little to do with the total area burned. As severe burns healed, the dead tissue formed a hard leathery layer called eschar. When this formed across the chest, it could become so tight that the chest could no longer expand properly during breathing. Some soldiers survived the initial shock, only to die days later because they physically could not take a deep breath. Doctors eventually developed a procedure called an escharotomy. During this operation, surgeons cut through the hardened tissue to relieve the pressure and allow the chest to expand again. The procedure was improved during World War II and the Korean War because so many burn victims were dying from this problem after surviving the initial injury. Burns to the hands were usually survivable, but they often caused permanent disability. The hands contain delicate skin, tendons, joints, and muscles that are easily damaged by extreme heat. As the burns healed, scar tissue tightened and pulled the fingers into fixed positions. Without intensive physical therapy that began soon after the injury, many soldiers permanently lost the ability to use their hands normally. The U.S. military officially stopped using backpack flamethrowers in 1978, but during the Vietnam War, napalm remained a major weapon. Instead of being sprayed from handheld flamethrowers, it was dropped from aircraft. U.S. Navy and Air Force planes used M47 and M74 napalm bombs throughout the conflict. The burns caused by these weapons were physically the same as those caused by flamethrowers, and Vietnam produced some of the most detailed burn records ever collected. The best-known civilian survivor was Kim Phuc Van Thi. On June 8, 1972, she was photographed running down a road near Trong Bang in South Vietnam after a napalm strike hit the area. She was only 9 years old. She suffered third-degree burns over about 30 to 40% of her body. She reached a hospital in Saigon roughly 2 hours later. Although that would be considered slow by modern standards, it was faster than many civilians received treatment during the war. She survived after 17 surgeries and spent 14 months in the hospital. For burn victims who survived the first 2 or 3 days, a new set of dangers appeared. These dangers killed more slowly, but they were often just as deadly as the original burns. Burned skin does not simply disappear. The damaged tissue becomes dead, warm, moist, and rich in nutrients, creating the perfect environment for bacteria to grow. Without the protective barrier of healthy skin, bacteria from clothing, dirt, the environment, and even the patient's own body can quickly enter the wounds. During World War II, one of the most common bacteria found in burn wounds was Streptococcus pyogenes. By the Korean War, another bacteria called Pseudomonas aeruginosa had become one of the leading killers of burn patients. It thrived in burn wounds and was extremely difficult to treat. Before penicillin became widely available in 1944, infections caused most burn deaths that did not happen immediately. Many soldiers who survived the initial shock of a flamethrower attack during World War I and the early years of World War II died a week or 2 later from sepsis. The infection spread from the wounds into the bloodstream and overwhelmed the body. Severe burns also placed enormous demands on the body's energy supply. To repair damaged tissue and fight infection, the body dramatically increased its metabolism. This condition is called hypermetabolism. Burn patients often needed 50 to 100% more calories than normal. In simple terms, they needed almost twice as much food as a healthy person. On a battlefield, providing that much nutrition was nearly impossible. Many burn victims slowly became weaker as their bodies burned through muscle tissue for energy when enough food wasn't available. Dr. Curtis Artz, a U.S. Army surgeon who treated burn casualties during the Korean War, later published research showing that nutrition played a major role in survival. Patients who received aggressive feeding had much better outcomes than those who did not. Statistics can explain survival rates, but they don't fully capture what surviving a flamethrower injury was actually like. Burn treatment requires a procedure called debridement, where doctors remove dead tissue from wounds to prevent infection and help healing. This had to be done repeatedly, often every day, for weeks or even months. Before modern pain management, many survivors described these treatments as worse than the original injury. The edges of burn wounds contained living nerve endings surrounded by damaged tissue. Even light contact could cause extreme pain. Nurses and surgeons often wrote that burn patients experienced some of the worst pain they had ever witnessed. Morphine was the main painkiller available during World War II, but supplies were often limited. Doctors also had to be careful because large doses could slow breathing in patients already suffering from lung damage. Medical reports from both Europe and the Pacific described burn victims screaming for hours before enough medication became available. The psychological damage could be just as severe. In 1946, military psychiatrist Dr. John Russell studied World War II burn survivors and found many suffered from nightmares, flashbacks, depression, and social isolation for years after the war. The worse the burns were, the more severe the emotional trauma tended to be. In conclusion, the medical record, accumulated across more than a century of warfare, tells that in an enclosed space, a soldier hit by a flamethrower was typically dead within 30 to 90 seconds. In open terrain, without any medical treatment, survival time scaled directly with the percentage of body burned. Burns covering more than 70% TBSA were almost universally fatal within 1 to 3 hours from fluid loss and shock. Burns covering 40 to 60% led to death within 4 to 24 hours without treatment. Burns covering 20 to 40% in a young, healthy soldier could allow survival for 24 to 72 hours without treatment, and full survival with rapid, skilled medical care.